Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
I love talking about Broward Health. I'm very much a part of it, and I believe in it so much. And if you would just see the many physicians who are involved with Broward Health, you would understand why it's really the greatest organization. But one specific gentleman, one physician whom I've grown very fond of and who is always there trying to help with them is now in a new position. And I wanted to welcome Dr. Dan Westphal. And Dr. Westphal, let's talk about exactly, and I'm going to just read this so then you can explain, it's a name, but you're still the same guy. Anyway, you are now the VP Designated Institutional Officer. So tell us what that means.
Well, that's actually a fancy title for stating a job that I actually do as Graduate Medical Education Director. The person that's responsible for our residency program. For those of you that don't know, after a physician finishes medical school, 4 years, they do an internship. That's the first year of the residency. Now, they used to call that internship, and they still refer to that as internship, but we now refer to it as a PGY1 level. In the years gone past, when an internship was started by a physician, the internship basically would consist of a number of different rotations, OB, pediatrics, internal medicine, etc. But now it's become very specialized so that we really don't refer to the general rotating intern as we used to. We now what are called straight interns, and straight interns are PGY1 level interns, and they are specific to a program. You can have a PGY1 in a general surgery residency, you have a PGY1 in an orthopedics residency, internal medicine, pediatrics, etc. So many times in the past when we talked about the rotating internship, when you got finished with the rotating internship, you would then have to take additional years in that particular specialty. For example, in my specialty, which is internal medicine, the PGY1 or the old rotating intern would have to then go on to the second level. But now the way it works is a PGY1 is the first year of your residency, not your second, like it had been in the past.
Wow. So it sounds like you've kind of invented and reinvented something that's could be very good for the patient, ultimately, what's going to happen. But what I wanted to just ask you, is this a national program? And you, of course, are running the Broward Health program, but is this something that all hospitals do? Well,
teaching hospitals do, and we usually have two categories of teaching hospitals. One are academic medical centers, such as the University of Miami, and then there are community-based programs like ourselves, like Broward Health Medical Center. We do have an affiliation, but our primary affiliation is not academic. It's community-based.
And I'm just curious, where do you get these stars from? Because you can't just get anyone. You have to make sure they have a lot of potential. Do you have any part in that?
Yes, there's a whole process, and just to explain it a bit, as physicians-to-be come out of their fourth year of medical school, they start applying for residencies. And so then we on our side, they will choose their designated institutions that they want to be training in, and then we will then choose them based on academia. So then in February, March, we have what's called a National Residency Matching Program. So then that day, there's a company that actually matches up the people who want to come to Broward Health with those that we do or don't want. And we actually did very well this year. We matched in all of our categories.
Okay, well, that's pretty exciting stuff. So do you find that when someone is an intern that they then wind up staying, or
That's the general intent.
That's what you would like,
The general intent for a graduate medical education program is to not only train physicians, but to also have them serve in the community once they've gotten finished with their training program. And what I've done is looked at the community needs analysis on the kind of physicians, the number of physicians that we need, and we're tailoring our training program to that end.
So do you actually go out yourself to medical schools? You don't do that. You let them
No,
come
we
to
actually,
you.
it's kind of interesting because we actually have affiliation agreements with different schools. So the students can come there their third and fourth year, like, for example, Nova, University of Miami, FIU, and other schools, even more remote, can come to Broward Health Medical Center. So it's always good for them to come and see what it's like before they actually apply for the residency. But it's nice because we get to know them a little bit when they come as students.
Good. Well, this is an extraordinary position for you. I know that you've had some wonderful positions there before. You were running, all the physicians had to report to you. But I think a person like you, this is fit for you because you're a very inspirational person. And if you can inspire those new doctors to have the right attitude and care about people and not so much their paycheck, I think you would be doing a great service, whether they stay with you or they go somewhere else.
Correct. I think the ultimate responsibility is not just to the community, but to society in general. When I sign their diploma, I have to make sure that they've achieved all of the different milestones and accomplished all of those things that would allow them to go out into the community. And we have a number of physicians that have already gone out into the community, and we're about to graduate another class, which will be, our graduation is on June 16th, Saturday evening. So we will have, I'm not sure how many, but probably about 40 residents that'll be finishing up and will be getting their final, if you would, diploma.
Wow. So so now let's think about this. How many interns do you run simultaneously? Do you actually are in charge of?
Just to give you an idea, we have 14 internal medicine residents. We have 8 pediatrics. We have 4 transitional a year, 4 family medicine, 3 orthopedics, 2.
He's not reading either. He's doing this from his mind.
2 to 3 dermatology residents. We have 4 pharmacy residents and OMFS, which is also part of our program, which is oral maxillofacial surgery, which is actually not under ACGME. It's really under the American Dental Association. And that's actually run by Nova, and it's actually a really good program.
You're learning a lot here, aren't you? I mean, it's like, no, really, think about this. If you have not done this before, so you're probably learning as fast as you can to be able to keep up with them because they have to look to you. And you have to know all the physicians. That's why this is a perfect position, because you have to know all the physicians that they're going to be working with.
Well, that's correct. And to kind of give you a little idea of the structure, for example, I am the DIO, the designated institutional officer or official, but under me, the director of GME reports, as well as the program directors. The program directors, there's a program director as a physician for each program that we have, and then working with them is at least 1 or 2 coordinators as support personnel. It's a very complicated and involved process that we deal with, but the program directors are really the ones that do the hard work. My hat is off to those that run the programs because I especially work closely with internal medicine, to some extent transitional year. And I think with that being said, we look at some of those things that we try to evaluate from the standpoint of the competency, because when you look at it, it's really, there are 3 things you have to think about. There's skills, there's knowledge, and there's attitude. But one of the things that you referred to earlier that I think is the big challenge is professionalism, because we know one of the big factors for physician burnout has been the demonstration of the increased number of suicides among residents and house staff.
Oh, I don't know that.
And interns, actually in New York, just 2 weeks ago, there were 2 residents that committed suicide, and they had a very robust, what they call, wellness program, where they would meet and talk about all their stresses on almost a daily basis, but they still can't figure out, because there was no indication in either of the individuals that they were suicidal. So we always have to be aware of that. So we do concentrate a lot on physician wellness, prevention of fatigue. If, for example, we see someone is fatigued, or if they've worked more than their 80 hours a week, we tell them to go home. And they want to stay, but we don't let them stay because they really need to get their rest.
Wow, this is great. We have 2 people watching right now. We have Ina and we have Lenore. So I'm glad they're listening, because this is pretty exciting to have, to have Dr. Westphal on. As a matter of fact, after, you can go to ANITA FINLEY Facebook page, and you'll be able to get the whole this whole conversation. Of course, it'll also be played on the radio, and we're going to put it on YouTube. But I am thrilled now. I didn't realize till you arrived that you had such a new but such a exciting position that you're going to be responsible. So now my question is, just talking about the suicide, and I don't want to dwell on that, but the fact that under what you're going to see, will there be people who just realize now that they're in this, it's not what they want to do? Is that common?
I think that there's some of that, but I think also they're just burnout from the workload. And the workload to us that in the old days worked a lot more hours find it a little bit hard. But on the other hand, there's a lot. When you start evaluating what an individual has to know just in a training program, it's a wealth of information. In fact, I was looking at the orientation materials yesterday for a pediatrics program, and it's almost 2 pages. All the things that they have to do, be responsible for, and because although they're residents in the GME program, they're actually employees of Broward Health as well.
Okay, but now people can transfer. Once they're in, let's say they thought they wanted to be a pediatrician, but now they got into cardiovascular and say, "Oh, I really want to do that." Is that allowable?
Yes, they can. Yeah, they can transfer, and in fact, when they do transfer, which fortunately we have very, very few transfers, but when people do transfer, we have to make sure that all the milestones have been achieved, or the milestones, or their level of competency is probably a better way to term milestone, has been achieved, because we don't want that person going to another program and not having achieved certain levels of competency, proficiency, and professionalism.
And you said that there's going to be a graduation. How long you said, is it 4 years? I mean,
well,
how long
it depends
do they
on the
have to
program.
be an internship?
Pediatrics and internal medicine are 3 years. Orthopedic surgery is 5. Dermatology, I believe, is 5. And they all vary. There are different levels. We have some occasion to get a PGY4, but that's PGY4 in internal medicine, for example, is someone who's a junior staff member. They're on the staff, but they're really still involved with the training program. We don't have any PGY4s. Most of the physicians either want to go directly into practice. Many of the internists, for example, go into hospitalist medicine, and about half of them go into specialty. So many of them will finish the residency. Like I was just talking with a physician this morning, and he said he was going into cardiology. So he's finishing up 3 years. He's got more years to go with cardiology.
And so that's what I was thinking, because as they're in, and so you have to put them with a particular, physician who you think you match them up.
Well, we match them up, but in addition, they have different rotations. Like there's some that are required for internal medicine. The requirements are ICU, intensive care unit. They have to work there. They have to work in the emergency department. They also have to spend a lot of their time, the first 1 year to 2 years, working on a general medicine ward or general medicine service. At Broward Health Medical Center, we have 5 medicine services. And for each of those, we have a core faculty person. So right now, we're going, the big transition right now, I just was able to choose a program director, excellent program director, actually trained at Broward Health Medical Center, actually did her medical school at Nova Southeast University, but we're I guess we're probably just going through for hiring faculty. You have, according to the ACGME, you're supposed to have at least 4 or 5 faculty, but they have to be paid faculty. The ACGME world has transformed from voluntary faculty to paid faculty. And in fact, when I was at the ACGME meeting a couple of months ago, I was actually speaking with some of the other DIOs from around the country, and they looked at me like I was a unicorn when I said we have volunteer faculty, because that's just not something that's done except maybe in small rural hospitals. Now with that being said, not all faculty members get paid. We have a lot of voluntary faculty. And in fact, they're really the backbone of the program, is being able to send people to different practices. We have outpatient facilities, so we do have to have an ambulatory experience for pediatrics and also for internal medicine. What's interesting about that is these physicians are seeing these patients, and they are seeing them as a continuity clinic. So when they start, they try to continue to see the patients, which is a very important part of the experience. That's what they're going to have when they're out in practice. So we have a mix of ambulatory along with the other disciplines. Now, for example, internal medicine and some of the other residencies, as they get further along from the first year or two, where it's really core, then they can choose to do electives. Like we have several electives. We have a pulmonary elective. We have a diabetes elective, a GI elective, cardiology elective. And we're kind of revising some of the electives because we found that many times when we look at physicians that are in practice, they're no longer just doing inpatient medicine like they used to. Years ago, when you were an internist, you did internal medicine, but part of that was ambulatory. But now there's a much greater emphasis on ambulatory. And what we're trying to do now is we're trying to split up. And in fact, I just did this. We have 2 excellent endocrinologists out in Coconut Creek that are employees of Broward Health. So I went out and spoke with them, and I said, our residents who are doing internal medicine elective for endocrinology are only seeing diabetes in the inpatient setting. We really need to have them have an ambulatory experience. So I'm trying to set up some of the electives so they'll do 2 weeks of inpatient, 2 weeks of ambulatory and outpatient, because a lot of that is what they're going to be experiencing if they go into practice.
So what pressure does that put on those physicians you've just asked to help you with this?
Well, they volunteered, and they were thrilled. They were very happy. I think most people, physicians that are involved with teaching, do it because they want to do it. I think as part of our professionalism, we feel that it's our obligation and our duty to pay back what we received. I know I had some phenomenal mentors in my, not only medical school, but training. And there's some people that I will always admire for all of my life because they were the people that helped shape me. And that's what our obligation is to try to help shape these physicians. And to your point, I want them to see what the joy is of medicine and practicing medicine, not going out to try to make a buck. If you've done that in medicine these days, except for very, very few specialties, you've really done it for the wrong reason. And I think that was actually demonstrated in a study that was done about 1.5 years or 2 years ago, where they looked at physicians who really were doing in medicine, if you would, for the money versus those that really enjoyed forming a relationship with their patients, and it was about being a doctor. And they found that the latter group was much, much happier. They found generally that there was more burnout and discontent, unhappiness, divorce, etc., among the former group than the latter.
Right. Well, you and I could have told them that anyway.
We could have. We
Right.
didn't have to do a study for that.
But that's wonderful. And you are so perfectly suited for this position. I didn't know it was even out there because I knew you before, but I am so happy to hear this. Well, if someone wants to be, this is kind of out in ballpark, if someone wants to be a diagnostician, they really want to be a person that you go to for second opinions. Is there any kind of a course for that, or is this just natural?
No, I think that, all of us have done second opinions, and I think a professional is the person who's capable of doing a second opinion. Most people think, well, I've got to go to an academic medical center to get that, and sometimes that's true, sometimes it's other physicians in the community, but the term diagnostician is really something that refers to primary care, primarily to maybe not so much to primary care, but internal medicine, I think, is especially as a whole, people refer to as diagnosticians. But they should be diagnosticians. That's their job. That's what they're trained to do.
Yeah, but there are people who are better at that than others, and I guess that's
human nature.
Right? That's in human
That's
nature.
human nature.
No, you're absolutely right. But when they're finished with this program, but before they're finished, probably in their third year, aren't they pretty much sure where they want to go? I mean, are other are other hospitals already contacting them, and do you get a chance to guide them?
Well, I think, yes, there are opportunities. More it's looking at career opportunities and choices about what they want to do
where they want to live.
Graduation, where they want to live, where they want to practice, what kind of practice, how many people, do they want to do private, do they want to do group practice, they want to be in a practice like Broward Health physician group where they are employed. So there are a lot of different choices, and I've had some of them come in and sit down, and that's kind of a nice compliment, sit down and say, can I talk with you for a little while? Usually more than a little while, but I think that's the whole idea, is you want them to confide in you, because I've been around a lot longer than they've been alive, for the most part.
Now.
Well, I hate to, but it's true.
Yeah.
I mean, and some of these are just kids, and they really can use the advice, and they need a lot of support. Like, for example, we saw that they were getting tired toward the end of the year, and we actually put money in for a burnout party. And they all went bowling.
it.
No drinking. I said if they drink,
Right.
that's on their own. But
Right.
we did. They had a wonderful time, and it was a good turnout, I think, like 40 or so.
Yeah, I'm sure they all feel the pressure on all things. And, of course, they're still having to pay back the tuition. I mean, there's a lot of pressure. And then some of them are married, and they probably have a wife who's saying, I want to go move out to, California where my family is, right? And it's so.
Well, it's true.
But how do they wind up here at Broward Health? I think you mentioned that before, but so if people are listening now and they have sons in medical schools or daughters in medical schools, how do they decide that this is the place they want? Are they going to talk to you first?
Well, what they'll many times do is they'll look at different affiliations. Like they'll say, I want to go to 2 or 3 different hospitals and do a rotation. So that's how they really get the experience, and that's how they really get molded by the residents, because the residents that we have a good experience, then that attitude, if you would, and the professional aura is going to follow them, and they'll see that and they'll want to come. I think we're going to have a much better match this upcoming year because I've set the standards higher and the expectations higher of what we want to see. Some of the programs, like for example, pediatrics is an excellent program. They match well. Orthopedics matched all of theirs. Dermatology matched their top choices. So did OMFS. We did not in internal medicine match the top choices. So we've got some work to do. Part of that relates to the fact, not making excuses, but part of that relates to the fact that we didn't have a program director full-time. We had someone from a physician who was excellent, but he was only there part of the time, and he was at FIU primarily. So I think having the stability of having a program director there full-time will also run the ambulatory clinic at Broward Health Medical Center, and in our plantation offices will be very important because it'll add a lot of stability, I think, to that program. So I think with that in mind, we'll see a lot higher choices this year than we matched this last year.
So this is the tough question. So now you're there and you're observing, and there's someone that just doesn't seem to be cutting it, and you just don't think they're going to fit in. What do you do?
Well, there's a whole prescribed process called remediation. And fortunately, with the physicians-to-be in remediation, we've had really good success. We're not always successful, unfortunately, because sometimes you just can't correct different things in residents. But for the most part, our remediation process is very robust, and it consists a lot of having a closer mentor, somebody who's watching you, meeting with you on an ongoing basis, like once or twice a week, but also giving you assignments, because some of it can be competency, some of it can be knowledge-based. So some of these people in remediation, some of the residents in remediation have done extremely well and actually risen to the top, and it's really nice to see that. We have one particular individual I can think of off the top of my head who really, the physician who was his mentor really took him under his wing and put him through the paces. Now he's one of the top residents. So that's, I think,
right.
The rewarding part of GME is to see these young people who, are smart to begin with, because they've got to be in order to not only get into medical school, but then to match in programs. So we see a high caliber of physicians that are graduating, not only in schools of osteopathy, but in schools of allopathy and MD versus DO schools.
Yeah, so it's the position is huge. I hope you're going to sleep well at night.
I do. I sleep very well.
Because you're happy about the position. It sounds like you're looking at the opportunity. So now let's talk about the TV shows about hospitals.
Something I never watch, Anita. You're asking the wrong person.
Right, because we see that's where we get our, we don't get a chance to do what you do, so we have to look at those TV shows and see, is that what really happens? And there are some strange characters on there, some really weird characters, but the one that I've liked lately, and I don't know the name, I don't remember it now, but there's a young doctor who has, what is the disease? It's, let's see, I forget the name of it now, where he isn't quite there. He can't. His attention is not.
Attention deficit.
Yeah, but there is a show, and I forget the name of it, where he is brilliant, but he also has something Burger. What's the
Asperger's syndrome.
Asperger's syndrome. He has this, and he's the most brilliant, but he's weird, and everyone tries to do what they're supposed to do, and then he'll stand there and he'll say, "It's this," and damn if it isn't that, right?
Yeah.
So, that has been a very popular show now because of him. And I don't watch it often. I just have caught it a few times. But I'm sure there are very special people that you run across that maybe they're a little bit, like a pesky mosquito, but yet they're really brilliant. And sometimes you want to put up with that.
Well, and I think, though, that you have to look at that as an outlier because there are some people that are very, very bright that are not eccentric. There are some that are eccentric. But I think the big focus in medicine now, you no longer can be the Lone Ranger, so to speak, in medicine. You really have to be a team player. And that's one of the things that we talk a lot about. And I relate a lot to my own experience of when I ran the ICU at Broward Health North, because we had a team. We had a flattened hierarchy. I told the nurses when they saw a problem, they could go ahead and order a test or do what they had to do. If they were suspicious, and they would call me. There was always just a very close camaraderie, and that's what you want between physicians and nurses. You want to have that very close relationship so you can work together without fear of people yelling or throwing instruments. And I think that there's a lot more emphasis on teamwork and
trust factor.
Trust. That's correct. But, trust is earned. So
yeah, that's true.
Physicians, like most of us in training with nurses, the older nurses, we actually had to have people who guided us. And some of them were not very nice. But, they did it out of the right intention, I think, for the most part.
Well, Dr. Westphal, this is so wonderful. We're going to have to get you back in maybe about 6 months from now so we can see how the program's going. I mean, this
Give you an update.
Thank you so much for coming and taking your time to do this because we learned so much, and I know they're in good hands with you.
And we only touched on a little bit.
My goodness. Okay, well, maybe I have to get you back before 6 months. Okay, thanks so much.
Thank you for asking me.